Welcome to the July 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the July issues of the journal, as well as commentaries by Dr. Jaron P. Sullivan on the article entitled Patient Outcomes After Observation versus Debridement of Unstable Chondral Lesions During Partial Meniscectomy, the Chondral Lesions and Meniscus Procedures, CHAMP, Randomized Controlled Trial, and Dr. Brian K. Lee on the articles entitled The Influence of Shortening on Clinical Outcome in Healed Displaced Midshaft Clavicular Fractures After Non-Operative Treatment, and Treatment of Displaced Midshaft Clavicle Fractures, Figure of 8 Harness versus Anterior Plate Osteosynthesis, a randomized controlled trial. Be sure to check out this month's Current Concepts Review article, Meniscal Repair, Reconsidering Indications, Techniques, and Biologic Augmentation by Dr. Jared M. Woodmass and colleagues. The authors review the anatomy and function of the meniscus, evaluate the implications of meniscectomy, and assess the techniques of and outcomes following meniscal repair. They note that a healed meniscal repair results in improved long-term functional outcome scores compared with partial meniscectomy, and that meniscal repair has been shown to be protective against the development and progression of arthritis. Advancements in surgical techniques and biologic augmentation have expanded the indications for meniscal repair to include tear patterns previously considered irreparable. Extensive research is currently underway to improve healing rates. The authors discuss mechanical stimulation, marrow venting procedures, the use of fibrin clots, platelet-rich plasma injections, and stem cell-based therapies. In this issue, JBJS.org presents a new image quiz, a 64-year-old woman with slow growth on her leg. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Patient Outcomes After Observation versus Debridement of Unstable Chondral Lesions During Partial Meniscectomy, the Chondral Lesions and Meniscus Procedures, CHAMP, Randomized Controlled Trial by Dr. Leslie J. Bisson and Associates. Investigation performed at the Department of Orthopedics and Sports Medicine, the State University of New York at Buffalo, Buffalo, New York. It is unknown whether unstable chondral lesions observed during arthroscopic partial meniscectomy, APM, require treatment. The authors examined differences at 1 year with respect to knee pain and other outcomes between patients who had debridement, CL-DEB, and those who had observation, CL-no-DEB, of unstable chondral lesions encountered during APM. Patients who were 30 years of age or older and undergoing APM were randomized to receive debridement or observation of unstable outer bridge grade 2, 3, or 4 chondral lesions. Outcomes were evaluated preoperatively and at 8 to 12 days, 6 weeks, 3 months, 6 months, and 1 year postoperatively. Outcome measures included the Western Ontario and McMaster University's Osteoarthritis Index, WOMAC, Knee Injury and Osteoarthritis Outcome Score, KOOS, Visual Analog Scale, VAS, Pain Score, Short Form 36 SF36 Health Survey, Range of Motion, Quadriceps Circumference, and Effusion. The primary outcome was the WOMAC Pain Score at 1 year. T-tests were used to examine group differences in outcomes, and the means and standard deviations are reported. There were no significant differences between the groups with respect to any of the 1-year outcome scores. Compared with the CL-DEB group, the CL-no-DEB group had improvement in the KOOS quality of life and SF36 physical functioning scores, as well as increased quadriceps circumference at 8 to 12 days, had improvement in the pain score on the WOMAC and KOOS at 6 weeks, had improvement in SF36 physical functioning scores at 3 months, and had increased quadriceps circumference at 6 months. Conclusions. Outcomes for the CL-DEB and CL-no-DEB groups did not differ at 1 year postoperatively. This suggests that there is no benefit to arthroscopic debridement of unstable chondral lesions encountered during APM, and it is recommended these lesions be left in situ. Next, you'll hear a commentary by Dr. Jaron P. Sullivan on the article entitled Patient Outcomes After Observation versus Debridement of Unstable Chondral Lesions During Partial Meniscectomy, the Chondral Lesions and Meniscus Procedures, CHAMP, Randomized Controlled Trial.
This is Dr. Jaron Sullivan providing commentary for the July 2017 JBJS podcast. I will be providing commentary on the article entitled Patient Outcomes After Observation versus Debridement of Unstable Chondral Lesions During Partial Meniscectomy, the Chondral Lesions and Meniscus Procedures, CHAMP, Randomized Controlled Trial. The title of my commentary is No Need for Chondroplasty. There are a wide variety of cartilage lesions that are identified at the time of knee arthroscopy for partial meniscectomy. The ideal management of cartilage lesions is unknown. In general, lesions that appear stable are left alone, and lesions that appear unstable are treated with a chondroplasty or microfracture. Chondroplasty is the most commonly employed treatment for unstable cartilage defects, and microfracture is the second most common treatment. The accepted practice is to debride the unstable lesion, but it is not evidence-based. The study by Bisson et al., Patient Outcomes After Observation versus Debridement of Unstable Cartilage Lesions During Partial Meniscectomy, the Chondral Lesions and Meniscus Procedures CHAMP randomized controlled trial, was designed to provide evidence either for or against the debridement of unstable cartilage defects. The CHAMP study is a well-thought-out, double-blind, randomized controlled trial that compares the management of unstable chondral lesions found during arthroscopy for a partial meniscectomy with debridement versus no debridement. The primary indication for surgery was a meniscus tear that failed to respond to conservative treatment over a 3-month period. In light of recent publications, this may not be the optimal indication for surgery for meniscal tear. The Fidelity Finnish Degenerative Meniscal Lesions Study trial demonstrated no benefit for partial meniscectomy in the setting of patients who had a degenerative meniscal tear with no evidence of arthritis. Patients in the Fidelity trial had at least 3 months of symptoms and had failure after conservative treatment modalities, similar to this patient group. Degenerative tears are certainly more common in older individuals, and the average age in the present study was approximately 54 years. If that is the case, then the majority of the patients in this study may not have needed any surgery at all and would have done equally well. It is unfortunate that this study does not have a third control group treated with physical rehabilitation. The study focuses on unstable cartilage lesions that are defined as greater than 1 centimeter squared with flaps that could be displaced greater than 5 millimeters with a probe, or that were greater than 1 centimeter squared and contained fibrillated cartilage involving greater than 50% of the depth of the cartilage. It would have been helpful to include images of lesions before and after debridement for each grade of cartilage injury. The study does not distinguish between the treatments of frayed cartilage versus cartilage damage with flaps. Flaps seem more likely than frayed cartilage to cause mechanical problems or issues with eventual loose bodies or propagation. A subgroup analysis of unstable flap debridement compared with frayed cartilage debridement may have shown a clinically relevant difference in improvement after surgery. Several appropriately selected and validated patient-reported outcomes are used to evaluate the treatment effect. The outcomes are evaluated at an appropriate time period for partial meniscectomy. The standard deviations for each group at each time point are wide, suggesting that the response to both treatments varied widely. In addition, the authors do not mention whether there were any reoperations, complications such as insufficiency fractures, or other failures, which could differentiate the outcomes in the two groups. There is scant literature on this clinical topic, none of which are randomized controlled trials, so the study adds an important contribution to the literature. The conclusion that unstable cartilage lesions do not need debridement could have a dramatic impact on practice management, save healthcare dollars, and improve early patient outcomes. Because of some weaknesses in the study design, it does not map out the exact course of management for unstable cartilage lesions, but it clearly challenges the practice norm of debriding all unstable lesions.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Predicting and Preventing Loss to Follow-Up of Adult Trauma Patients in Randomized Controlled Trials, an example from the FLOW trial by Dr. Kim Madden and Associates. Investigation performed at McMaster University, Hamilton, Ontario, Canada. High loss to follow-up rates are a risk, even in the most rigorously designed randomized controlled trials. Consequently, predicting and preventing loss to follow-up are important methodological considerations. The authors hypothesized that certain baseline characteristics are associated with a greater likelihood of patients being lost to follow-up. Their primary objective was to determine which baseline characteristics are associated with loss to follow-up within 12 months after an open fracture in adult patients participating in the Fluid Lavage of Open Wounds FLOW trial. The authors also present strategies to reduce loss to follow-up in trauma trials. Data for this study were derived from the FLOW trial, a funded trial in which payments to clinical sites were tied to participant retention. The authors conducted a binary logistic regression analysis with loss to follow-up as the dependent variable to determine participant characteristics associated with a higher risk of loss to follow-up. Complete data were available for 2,381 of 2,447 participants. 163 participants were lost to follow-up. Participants who received treatment in the U.S. were more likely to be lost to follow-up than those who received treatment in other countries. Male sex, current smoking, high-risk alcohol consumption, and an age of less than 30 years all significantly increased the odds of a patient being lost to follow-up. Conversely, participants who had sustained polytrauma or who had a Gustilo-Anderson type 3A, B, or C fracture had lower odds of being lost to follow-up. Conclusions. Using a number of strategies, the authors were able to reduce the loss to follow-up rate to less than 7%. Males, current smokers, young participants, participants who had consumed a high-risk amount of alcohol, and participants in the U.S. were more likely to be lost to follow-up even after these strategies had been employed. Therefore, additional strategies should be developed to target these high-risk participants. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled The Influence of Shortening on Clinical Outcome in Healed Displaced Midshaft Clavicular Fractures After Non-Operative Treatment by Dr. E.B. Gowdy and Associates. Investigation performed at the Edinburgh Shoulder Clinic, the Royal Infirmary of Edinburgh, Edinburgh, United Kingdom. The authors aim to evaluate the effect of clavicular shortening, measured with three-dimensional computed tomography, 3D CT, on functional outcomes and satisfaction in patients with healed displaced midshaft clavicular fractures up to 1 year following injury. The data used in this study were collected as part of a multi-center prospective randomized controlled trial of open reduction and plate fixation compared with non-operative treatment for acute displaced midshaft clavicular fractures. Patients who were randomized to non-operative treatment and had healed by 1 year were included in the present study. Clavicular shortening relative to the uninjured contralateral clavicle was measured on 3D CT. Outcome analysis was conducted at 6 weeks, 3 months, 6 months, and 1 year following injury, and included the disabilities of the arm, shoulder, and hand, constant, and short form 12 SF12 scores, and patient satisfaction. In the original trial, 105 patients were randomized to non-operative treatment. 13 patients were lost to follow-up, leaving 92 patients, and an additional 16 developed non-union and were excluded from the present study. Of the remaining 76 patients, 48 who had a 3D CT scan that included the whole length of both clavicles were included in the present study. The shortening of the injured clavicles relative to the contralateral side was a mean and standard deviation of 11.3 plus or minus 7.6 millimeters, with a mean proportional shortening of 8%. Proportional shortening did not significantly correlate with the constant, or SF12 scores at any point during follow-up. There was no significant difference in the mean or constant scores at any follow-up time point when the cutoff for shortening was defined as 1 centimeter or as 2 centimeters. There was no significant difference in clavicular shortening between satisfied and unsatisfied patients. Conclusions. The present study demonstrated no association between shortening and functional outcome or satisfaction in patients with healed displaced midshaft clavicular fractures up to 1 year following injury. Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Treatment of Displaced Midshaft Clavicle Fractures, Figure of 8 Harness versus Anterior Plate Osteosynthesis, a randomized controlled trial by Dr. Marcel Jun Sugawara Tamaoki and Associates. Investigation performed at the Department of Orthopedics and Traumatology, Universidade Federal de São Paulo, Escola Paulista de Medicina, Unifesp EPM, São Paulo, Brazil. Most midshaft clavicle fractures affect the economically active population, which is negatively impacted by transient limb impairment during the treatment. There is still debate about the advantages and disadvantages of surgical treatment for these fractures. In this prospective randomized controlled trial, 117 patients were allocated to one of 2 groups: non-surgical treatment with a figure of 8 harness or surgical treatment with antero-inferior plate osteosynthesis. The primary outcome was upper limb limitation measured with the disabilities of the arm, shoulder, and hand questionnaire at 6 months. Other outcomes included pain, radiographic findings, satisfaction with the cosmetic result, complications, and time to return to previous work and activities. Participants were assessed at 6 weeks, 6 months, and 1 year after the intervention. No difference between the two groups was detected in the DASH score at any time point. Pain levels measured with a visual analog scale, time to return to previous activities, or dissatisfaction with the cosmetic result. 7 patients developed non-union after non-surgical treatment, a non-union rate that was significantly higher than that in the surgical group in which all fractures had healed. The patients in the non-surgical group had radiographic evidence of greater clavicle shortening, and more of the patients in that group answered yes when asked if their clavicle felt short and if they felt bone prominence. More patients answered yes when asked if they felt paresthesia in the surgical group than in the non-surgical group. Conclusions. This study did not demonstrate a difference in limb function between patients who underwent surgical treatment and those non-surgically treated for a dislocated midshaft clavicle fracture. Meanwhile, surgical treatment decreased the likelihood of non-union. Next, you'll hear a commentary by Dr. Brian K. Lee on the articles entitled The Influence of Shortening on Clinical Outcome in Healed Displaced Midshaft Clavicular Fractures After Non-Operative Treatment, and Treatment of Displaced Midshaft Clavicle Fractures, Figure of 8 Harness versus Anterior Plate Osteosynthesis, a randomized controlled trial.
This is Dr. Brian K. Lee providing commentary for the July 2017 JBJS podcast. I will be providing commentary on the articles entitled Treatment of Displaced Midshaft Clavicle Fractures, Figure of 8 Harness versus Anterior Plate Osteosynthesis, a randomized controlled trial, and The Influence of Shortening on Clinical Outcome in Healed Displaced Midshaft Clavicular Fractures After Non-Operative Treatment. The title of my commentary is Midshaft Clavicle Fractures, the Saga Continues. A landmark article by Hill et al., which was published in 1997, shed new light on shoulder function after non-operative treatment of displaced midshaft clavicle fractures. The traditionally held belief that these fractures could generally be treated non-operatively was brought into question, and the controversy over the optimal treatment has continued over recent years. When the decision to treat a displaced clavicle shaft fracture non-operatively is made, one can expect the fracture to result in non-union or malunion. Gowdy et al. Present the results of non-operative treatment of patients with midshaft clavicle fractures that went on to malunion. A major strength of their investigation is the use of three-dimensional computed tomography to gain a more accurate measurement of absolute shortening and proportional shortening. While they found no difference between patients with final shortening of greater than 2 centimeters or less than or equal to 2 centimeters, the authors point out the relatively low sample size, 5 patients with greater than 2 centimeters of shortening for this particular cohort, and the overall low prevalence of that degree of shortening in malunions. Indeed, in the aforementioned study by Hill et al., no patient with greater than or equal to 2 centimeters of shortening went on to have union. Gowdy et al. Clearly state that their findings excluded all patients who went on to non-union, which has been consistently shown to be a factor for a poor outcome. The conclusions of their study should therefore be interpreted carefully. The shortening in a malunion, as studied in the present investigation, may be well tolerated, while initial shortening at the time of injury should still be seen as a substantial risk factor for non-union. Tamaoki et al. Aimed to compare the results of operatively treated clavicle fractures using an anterior plate and non-operatively treated fractures managed with a figure of 8 brace. The patients were randomized to treatment, and although 19 of 117 eligible patients were lost to follow-up, the study met exactly the required number of patients according to their power analysis. Interestingly, their study population comprised mostly male patients, although the disparity was not significant. A single anteroposterior radiograph, including both clavicles, was used to quantify shortening. The authors found no difference between the groups with respect to the disabilities of the arm, shoulder, and hand, or visual analog scale scores, and they observed a lower rate of hardware removal for symptoms related to the use of anterior plates compared with published data on superiorly positioned plates. Unfortunately, patients with non-union or malunion were not specifically studied with regard to outcome. While both studies described careful measurement of radiographs, and the use of three-dimensional CT scans in the study by Gowdy et al., they both allude to our current inability to reliably measure clavicular position. Radiographs, although more practical in general practice, are less precise than CT scan in measuring true shortening. Furthermore, malrotation is an important variable that was not measured in either study. Ristevsky et al. Recently examined the position of the scapula with three-dimensional CT scan in patients with scapular winging after clavicle malunion. The scapula can be expected to rotate anteriorly, medially, and internally as a result of its connection to the distal or lateral clavicle fragment. Such winging may result in diminished mechanical advantage of the shoulder, as well as shoulder dysfunction, and may be a confounding factor when outcomes of shortening and clavicle fractures are compared. These two well-designed studies provide further valuable insight into the ongoing debate on the optimal treatment of displaced clavicle shaft fractures. Their results largely support what has been shown in the literature previously, that is, non-union rates following non-operative management were 15 and 17%, and plate fixation was found to be a safe treatment option with a very high rate of union. In light of previous studies demonstrating poor results for clavicle shaft fractures with greater than or equal to 2 centimeters of shortening, a surgeon may have recommended surgical management of a shortened malunion. The study by Gowdy et al. Provides a well-designed investigation that allows us to better counsel that cohort of patients. Future studies, particularly those examining the position of the scapula following clavicle fractures, are necessary to help us identify which patients would most benefit from operative intervention in the setting of an acute fracture.
Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.